ahead, we now have our lightning talks, and for that, I'd like to invite on stage Anaita Singh and Dr. Akash Malik from the Bill and Melinda Gates Foundation. Anaita is a program officer of digital health, and her work seeks to leverage digital tools for equitable service delivery. She has worked extensively across India and Africa in public health, policy research, and strategic planning and analysis. In her previous roles, she led as a strategy head at Dimagi, India. Before that, she served as a specialist consultant at the Boston Consulting Group, where she developed a governance innovation model within the state public health system and launched MISAL, a public health scorecard aimed at driving health outcomes and ensuring the translation of state reviews into actionable measures on the ground. Anaita has also worked with the Clinton Health Access Initiative in Lesotho, Africa, where she led a World Bank-funded project to deploy mobile-first technology to combat tuberculosis and HIV. Dr. Akash is a seasoned public health specialist with over 15 years of experience on the field. He has led pioneering public health initiatives, including design and implementation of CoWIN, the world's largest real-time COVID-19 vaccination tracking initiative. He has also played a key role in the programmatic design of the UN platform to digitize India's universal immunization program. He has extensive experience working with the Ministry of Health and Family Welfare, including spearheading the initial rollout of the rotavirus vaccine across 10 states and serving in strategic positions within the National RMNCHA Unit and Immunization Technical Support Unit. His goal is to harness his extensive background in public health management and digital innovation to drive impactful global health initiatives. Over to you, Anaita and Akash.
How's the Josh? Very high or high? Okay. I'm Anaita and this is Akash. We both work together, debate together, try to come to terms with what we're trying to do together at the Gates Foundation. It's a privilege to be here. I think what we will probably start with, we have 20 minutes and we're a little behind schedule. So what I'm going to do is just take a step back. Before both of us joined the foundation, I joined 3 years ago and Akash joined about
2 years.
2 years ago. Just taking a step back on the role Akash was in, and my question is first to you, Akash, on COVID, and we heard that at the beginning of the session as well. What was your vantage point? What were you trying to do? Who were the stakeholders you were working with? And if you could share more about that national level journey where we were trying to bring public health convergence as well as digital.
Thanks, Anaita, and thanks to the PART team for organizing this, and thanks for every one of you for being here. So CoWIN, so I'll start with two very, stark, I will say, social media things which I saw, which actually stuck to my mind is, one is by a very famous RJ who does very beautiful, voiceovers. And his famous is the Lolo Dial Seva, right? I'm sure you must have heard about him. I think Kisna. He used to do this Lolo Dial Seva, taking, swans on his back to get CoWIN slots. And then there is a monkey who is trying to wash off clothes saying that CoWIN ne zindagi kharab kar di hai, slot nahi milta. So that is one impression of CoWIN. Second is an anecdote which was made by the Honorable Foreign Minister, Shri S. Jaishankar ji, where he said that he was having lunch with his daughter in UK, somewhere in UK during COVID times. And, some, officer came for them to show their kind of, proof of vaccination. So while his daughter was, struggling to get the paper where where the vaccination had been acknowledged, he just opened the app, CoWIN app, and showed the certificate. So he said that was, and he asked his daughter that, don't you have something like that in UK? And she said no. So very two contrasting things. So when we started with CoWIN, just wanted to highlight is, when we started about, it was launched on 16th of January, 2021, when we started about 5-6 months back. It was actually an Excel sheet, right? Because initially it was a very specific and very small cohort which was supposed to be vaccinated. And our idea was very simple, that we'll get data from various ministries, the frontline workers, on an Excel sheet, upload it into an application, and then we will organize sessions on the application, and then we will start the vaccination program. But when we started doing that, we understood that it's a big challenge, right? We need to have something which is more citizen-centric, which is more user-friendly, wherein the user can register themselves, rather than we asking for a data and doing a data upload using an Excel sheet, which was very primitive at that time of time, right? So that's how it started evolving, and the vision was very clear. Vaccine was in a shortage, and the idea was there should be no wastage of vaccine, so every dose needs to be accounted for. So every vaccination needs to be tracked, and because of the scenario, the questions being asked, it should be transparent. The beneficiary who's getting the vaccine should have an acknowledgement that, okay, yes, I have received this healthcare service, and this can be verified and kind of authenticated whenever and wherever I need. Third was that as the vaccination program expanded, we should be able to, the software should be able to take the load of the vaccination program, right? So and third, and the last one is obviously visibility and transparency. So even today, the covid.gov.in is live. You can see the dashboard. There is no password which is required. I'm sure most of you must have seen it. With 1.2 billion registrations, 1.11 first doses and 0.97 billion second doses still there, and state-wise coverage still there, right? So that was the level of transparency which we are talking about. And it was an amalgamation of public health experts, architects, technological, or I don't know the exact term, but the architects, the chief architects who designed it. Third is obviously the the database architects and the people who understood data and how it should be represented. Third is the team who did the UI UX, and fourth, leveraging everything was, and the program management which was led by the Ministry of Health and Family Welfare and the NHA. I think that partnership really between the NHA and the Ministry of Health and Family Welfare really paved out to what we see as COVID today.
Great. And if I were to just build on that and come back to the journey that states have taken, do you think that inspired states in any way? And I can probably give my examples as well from the work that I've done, but do you think that paved the way for a certain change at which digital was looked at, architecture was perceived with the NHA's ABDM coming in, or do you think it's still a long journey ahead?
No, I think, Anaita, states were always aware, right? And you are the best person to tell us about it. We had a very narrow vision when we were at the national level, saying that we are the only person who, do the innovations or know digital, right? But states had this cropping up for a long time, and I think COVID-19 pandemic gave them an opportunity to come forth and show what they can do as well. So actually, I would like to hear from you, right? Which I usually don't, but.
It's my good day today. Saturday is a
Yeah,
good day.
so I'm just feeling nice today so thanks to Varun and team. So, yeah, there you are. So, yeah, so what do you think, was boiling in the states when the COVID-19 pandemic came in? What preceded it? What happened during it, and what succeeded it? And how the digital health, kind of ecosystem has developed in the states, especially in UP and Bihar where we work?
Sure, no, thank you for that. And just changing gears a little on coming back to our roles, So Akash leads the Bihar work, so how our team is structured, just to even give visibility on that, right, how we come together. He's looking at the health system strengthening work for Bihar. And as Yates Foundation, we work in UPA Bihar primarily, given if we are to achieve the SDGs overall, that these were the two states which will have to come forward and make progress. I am a part of a cross-cutting team, as many of you who work on digital would understand that, I think understanding health in its length and breadth and depth is important, but enabling that in the right manner by leveraging digital is where the role my team comes and plays, and I come and play in. If I take a step back and I just take Uttar Pradesh as an example where we extensively work, I think, like you humbly said, and I'll humbly accept, they were on this journey for a while, and maybe COVID with all the implication that it had on population level health impact was one of those, events which actually accelerated that journey, but they had been on a journey for a while. So if I take a step back and, we've been supporting the government in Uttar Pradesh for about over 10 plus years, but they had been on this journey for a very long time in terms of at least getting the health system building blocks in place. That could mean supply chain strengthening, that could mean human resource management, and we're talking about a state with 75 districts. It's a very, very populous state. It can become countries in different formats if you want to look at it. And that journey has been on for a while. But in 2018-19, we had done this assessment through one of our partners who had basically analyzed the number of applications, mobile applications, and the chaos that entails, and the pilotitis that some of us bring in when we want to test new ideas and we are itching. We tested that and we realized that over a majority of those applications were just for administrative purposes. So governance, data collection using that. And if we are talking about enablement, it's exactly counterproductive because it's not a job aid, but it's just being able to get the data out so that you can extract something out of it for your purpose. That was one. I think the other was, there was aggregate systems, right? So if coming back to the role you were playing, supporting the Ministry of Health, everybody wants data. Everybody wants to look at data here today. And the way it's structured within the ministry and the way the programs are structured within the National Health Mission, very verticalized programs. So depending on, it's subjective. Who's the leader in that place, how much money has been allocated, how much they are able to drive. There were these, verticalized program applications that kept coming up. But what the state started to find, a little bit of momentum in was, coming back to your question, there was a lot of frustration when the CoWIN platform was evolving, right? Because states understand their context-specific, needs better. And that's where, taking UP as an example, they developed an end-to-end case management platform for COVID that included labs, facilities, public, private sector, right across the entire continuum of what a patient journey potentially could be. The interesting part here is that this happened when none of us could move out of our homes, right? Yeah. So at a time when an ASHA or an ANM still did not necessarily have a phone, especially the ASHAs, they were actually being trained virtually to adapt to actually understand how to use this system, and at the scale that it happened. I think that then also pushed the state to start pushing the national government to start giving APIs. Absolutely. To actually integrate rather than putting another Excel sheet to upload information and creating that ruckus. As we all understand, health is a state subject. So there is always this tussle, good or bad, between national level applications, state specific applications, how they want to envision the journey there. So that also got expedited, and I think, at least in UP, that actually gave a lot of momentum for the state and a lot of confidence with support from different partners in the ecosystem, public and private sector partners, to actually start looking at digital at a citizen level. So what CoWIN did at the national level, or what this unified COVID platform that the state developed, they have now started looking at the entire public health journey at a citizen level, digitizing the health workforce, right from the community level to the facility, secondary level, and now tertiary, and looking at that end to end. I think it's a long journey ahead, and of course the Ayushman Bharat Digital Mission plays a role there. But given our roles, and just shifting gears towards Bihar a little, Bihar has followed a different model. But I wanted to come back to the fact that when we are doing our day-to-day jobs, and looking at a little bit of tactical aspects there are a lot of challenges. This is the good story I've said. Now there are so many underneath layers around this story, right? So as you think about your role and bringing convergence between our roles and within the state system, building that capacity, if you can share with us what are those challenges, gaps, and I would probably frame them as opportunities which so many people in the room can actually potentially try to solve for, or see if they have any intersections when it comes to their roles in the ecosystem.
Yeah, thanks Anaita for giving the UP perspective, and it's really good that you are not crossing and cutting, and I'm not showing my system strength today. So so Bihar in fact is, as you said, started on a different tangent, and they have progressed in a different tangent where the state itself has taken a lot of ownership of what they are doing in terms of digital. Now, when we talk about challenge, one challenge which you clearly laid out is we don't tend to, this at the national level, we don't tend to understand what the state priorities or the state challenges are. I still remember when we were doing CoWIN, getting calls from the principal secretaries and mission directors, literally saying that, why you have added this feature, this is not useful for us, or this is what we need additionally. And that's where, as you said, the concept of APIs came in, and so much so that, Zomato, Ola, everyone started using that API so that what the delivery, executive has the certificate and you can view which dose he has taken or she has taken, right? However, there are still certain gaps in the sense that data, what is the visibility of data at what level is still a big question. There's a joke which I always make is that the highest official sitting at the Ministry of Health and Family Welfare needs to know that Lalita Devi sitting in Mirzapur district is pregnant, but Lalita Devi herself doesn't know whether she is pregnant or not. Right. So, and that was the challenge which we also, we had foreseen during COVID, that the beneficiary should have visibility of what services they are eligible to, and the acknowledgement that yes, they have received that service, and third, that whether if they want to, want to get it verified, then they should be able to verify it. So these were the three, I think these are three challenges. First is data visualization. At what should be the data visualization at what levels? Second is integration between what state is doing and at what the national level ministries are doing, where we can integrate. Third is, again, the scalability is a big issue, right? We tend to not foresee what is the scale which in terms of the variables or the data or the load which we'll have on the system, and we don't build our systems accordingly, right? So testing, yes, testing happens at different levels. So when we start testing an application, usually we start at a very small scale, but testing also needs to be done at a larger scale. I think in UP and Bihar also what we have done is we have done at a district level or maybe at a regional level before we actually started the state level rollout. Third is what happens once the leadership changes, right? Once the bureaucrats changes, right? That's the life which we live in, right? We spent couple of years, 2-3 years advocating for a particular application or a particular innovation or a particular intervention to be implemented, and once the bureaucrat gets transferred, the thought process changes, and again we are back to zero, right? So how should we take that forward, and how should we circumvent that challenge is another, I think, question which we need to answer. So yeah, that's from Bihar, which I see overall. Though I think UP and Bihar have done quite well in digital health, which was not expected. And at the national level also, it's a wake-up call. I think that states can take their own initiative, and the applications which are being developed at the national level should be open to share, to integrate with what the states are developing. So having said that, Anaita, what do you feel? How the various interventions which we have seen at the national level and spoken about at the state level have contributed to the overall digital health initiative of India, which is a kind of a dream which we are trying to implement in the form of Ayushman Bharat Digital Health Mission.
Thank you.
Sorry.
Thank you for sharing that, and thank you for the question. I'm going to answer this question with a question to the crowd. How many of you have created your Ayushman Bharat health account?
Me too.
Okay. Some of you may have not known it got created. That's a separate story. You can meet Akash later for that. And okay, great. That's great to hear. How many of you have downloaded any application or you use any platform when it comes to accessing your personal health records? So any PHR app. We just dwindled, right?
So just to add, PHR, so even if you're using a Max application or a Fortis application where you can see is a PHR application, right? So no.
No,
okay, so I'm wrong. See, I'm
also. Okay. And I will just cover that. And thank you for flagging that. A Max application or an Apollo application are still not using an ABDM-enabled solution. So you may be able to see all your, and my husband uses this, he uses a Max app, he looks at all his records on a very continued basis, but only the records that he has within the Max silo, right? But if you're using a PHR app and you're going to any clinician, lab, pharmacist, etc., who is also using an ABDM-enabled app and linking it to your Aadhaar, you can actually fetch that consent base, share it, etc., etc. But my point of doing this was coming back to your example of Lalita or anybody else where the ministry wants to see this information. We ourselves, if I may, a privileged group are still not using this. So the demand for this is still something that is work in progress. My short answer to your question is it's a really long journey. It's not just a journey about digital to be able to access your health records, have all of this together, but it's also a behavior change management journey. And I've used this example now twice, but I'm still going to share it. I was in Bihar on a field visit, and I was talking to an ASHA, an accredited social health assistant, activist at the last mile, and she had brought in a pregnant woman in a referral hospital. And the nurse there was super active, and she was using the Bhavya platform, which has been rolled out by the State Department across the entire continuum. And she was telling her, you should generate your Abha. And she was like, okay, what does it take? And she had a phone in her hand, right? She was like, what does it take to generate Abha? She said, you have your Aadhaar? She said, yes. तो फिर you said हिंदी समझ आती है, तो OTP आएगा, OTP उसमें डालना, फिर आपका generate कर देंगे. So she was like, OTP आएगा, मेरे पैसे ले लोगे. So then she explained, and everything happened and everything. And there was an auxiliary nurse midwife who was just standing there looking at all of this happening, who was friendly with the woman who had come in. She got convinced. Then she was like, इसका फ़ायदा क्या होगा? बन गया, ठीक है, इतने सारे ID बनाते रहते हो आप मेरे, ये भी बना लूँगी मैं, फ़ायदा क्या होगा? So she explained, the nurse, and this is what where context plays a role, right? She said, तुम lawyer के पास जाती हो कभी ऐसे केस कूस होते हैं तुम्हारे, तो सारे के सारे डॉक्यूमेंट्स पकड़ाती हो ताकि जीत के आए, तुम पूरा केस जिता के आए. तो वैसे अगर तुम्हें डॉक्टर के पास जाना है, तो लादने से अच्छा इतने डॉक्यूमेंट पता नहीं कहाँ रखती हो, अगर कहीं चढ़ा दोगी, डॉक्टर देख पाएगा. तो ये इसका बेनिफिट है. She nodded, like, okay, little skeptical. She was like, okay, कर देती हूँ. Suddenly the ANM walked in and she said, दीदी फ़ोन तो इसका है नहीं, तो जो नंबर है वो OTP इस पे तो नहीं आएगा. तो that entire, I'm just trying to bring it down to, abhi to we are still having conversations around, when we talk about the public health system, the denominator becomes really important, right? And many of you who may be working at the intersection of this would understand that, if you want to see immunization coverage, if you want to see antenatal care coverage, you need that denominator. And one of the biggest problems we've seen is with the multiple registers these frontline workers use across the care continuum, that denominator is always a, estimate based on FP percentages, right? Now, with Abha, we are hoping some of that can be changed, where the ASHA or the ANM does her enumeration, which anyway the survey she has to do every 6 months and annually in general, and she can start getting the denominator in place. But the point is, you do that one time, and then what? The communication around what that demand awareness would look like, even the health frontline workforce to be able to see across the care continuum how this actually impacts when they are providing treatment would be a journey of its own. And with that, one nudge, and then I'll pass it to you, Akash, and then we can probably close, would be that when you all are thinking about, in your spectrum of what you do, and it's a range in digital health of what you can contribute towards, maybe thinking about how we can strengthen last mile delivery much more innovatively, keeping that target audience in mind. And AI is the buzzword, so sure you can clap it up wherever, but there is still validation to be done and still guidelines to come in there. But thoughtfully thinking about some of these challenges could be an instrumental role that you can, actually contribute to. And if anybody's interested, we are here to talk about it. But Akash, back to you. What do you think this community can potentially contribute towards? And B, just linking it back that, you shared the challenges and the journey Bihar has had. What have been those gaps in terms of even expertise or roles different ecosystem partners can play and this community can contribute towards?
Yeah, thanks, Anaita. We are already at time, but as we discussed earlier, when we start speaking, we don't stop. Yeah. So let's stick to that. Sorry. So the community here is the Yodhas, right? And we expect that these Yodhas will take forward the digital health agenda going ahead, and will be able to pass on the baton what we are doing. That really feels like old, right? I was not able to register, by the way, right? Because I'm 35 above, maybe 4 years back. Yeah. So yeah. So I think for any any application or any digital system being built for a public health good, there are multiple requirements, right? First, is for the public health system to understand how they can leverage information technology and digital, and vice versa. The information technology experts and the digital experts to understand the public health system, right? So these two expertises need to work in tandem, right? And that then opens a plethora of opportunities for each one of you, right? Maybe someone wants to go to AI, as you mentioned. Someone wants to work on databases. Someone wants to work on UI, UX. Someone is from a public health, background and has the idea of what needs to be digitized, right? Also, before you start, and I was hearing, because I was sitting in the front, so, when Pallavi was talking that we have entrepreneurs and we have like startups, and there was someone sitting, I think a girl behind me saying that, no, startup, yes, I'll do that startup, right? I don't know who she was, but I probably heard her right. Whenever you plan something new, do a good exercise of what the problem statement is and whether something similar is already is available in the market or not, and how you can work together if there is something available. I think that's where we are currently lacking. And we tend to develop so much parallel things that, it's ultimately one thing which will work. Second, with AI, personally, I feel, because 2 days back, one of my plastic surgeon friends said there was a news item of, China developing an artificial intelligence digital or a hospital, right? Basically telemedicine, and as a glorified version of telemedicine. And he's just tagged that in the WhatsApp group and said that doctoroं की job जाने वाली है 5 साल में, which is not the truth, right? AI is not to replace what humans can do, but to assist the humans, right? Help them to be more efficient, right? And also to ensure that the services reach where doctors or where human resource may not be able to reach because of various challenges. India has lot of challenges, right? There are diverse kind of landscapes, diverse kind of, economic challenges or social challenges. But that does not mean that they people don't deserve what we are getting here sitting in Delhi, right? So how we ensure that services reach there. So understand what your problem statement is, what you're trying to solve, and whom you're trying to reach. Whether you're trying to reach everyone, to the person who has everything already, and just to add digital to that, or whether you're trying to reach to a person who is lacking that basic services which he or she is entitled for. So that is my perspective, but I'll pass on to you to add on.
I know we are at time,
Yeah.
so I think we can close with your perspective. But I think to what Akash said, right? There is fun in reinventing the wheel and being innovative about it, but there is fun in actually going onto the field and understanding and using, and also brokering the language. I think that always becomes a challenge between tech folks, between researchers, between public health specialists, between doctors, between folks on the ground, between beneficiaries, right? I think all of us will have to be a little more intentional when we're looking at even the data sets on which we are training AI solutions, as an example, when we're looking at what we want to specify as the problem. And we have Suhail here who leads our digital team, and you can also ask questions to him later. I just want to put him in a spot. But, a lot of times we also think about, and I will close with this, we saw 51% at least has representation of women here. So when you're thinking about design, how do you think about gender in that design? Because we keep giving examples of pregnant women. We did that with the image in the morning. We've done that twice in this conversation. But have you really designed your systems by understanding the ecosystem of that woman and leveraging digital to actually support her, whether it is risk stratification using AI, whether it's the continuum, whether it is referral pathways for her to get the right medication and the treatment on time. So I'll close with that. Thank you so much for listening to our chatter.
Thank you.
Thank you, Akash.
Thank you, Anaita.